Coming up today, it's been 1 year since the first adult patient got proton therapy here at the University of Kansas Cancer Center. Why was this advanced therapy right for her, even though technically speaking, she didn't have cancer? Good morning. I'm Jessica Lovell. It's Monday morning. Welcome to the Morning Medical Update. We talk a lot about proton therapy on this program because it really is an incredible treatment that reduces a patient's exposure to harmful radiation. It takes, though, some very smart experts to deliver that precise and painless proton beam directly where it's needed. 1 year ago, Lisa Webb was the very first adult patient here at the University of Kansas Cancer Center to lay down on the table and let the tiny beam of protons go to work. We look back at her story in this edition of Where Are They Now? "53-year-old wife and mother Lisa Webb knew something wasn't right.
My vision was more like an octagon. I was looking at objects, things, people, and it was just starting to get worse. And so I went to the eye doctor. They had no clue.
An MRI at the University of Kansas Health System revealed a tumor called skull-base meningioma. It was wrapped around the main artery of her brain and left optical nerve. Doctors removed some of the tumor, but not all. They recommended a radiation treatment plan that before now would have required Lisa to travel out of state for weeks away from her family.
We had this technology that was coming on board soon. I thought she would be a great candidate that could have significant advantages in her case.
For Lisa, it was worth the wait. She became the first adult patient to receive proton therapy at the University of Kansas Cancer Center. We spoke with her week 1 of her 5-week treatment.
I'm being positive, and I'm saying my rosary daily, going to Mass still on Sundays with the family, and just being positive.
And we were there just weeks later when she rang the bell. A joyful moment for her and her medical team.
Just, excitement and happy for Miss Webb that we were able to do this here and that she was able to come in, get her treatment, and then go back home and have dinner with her family.
And those really smart doctors and experts that I mentioned off the top of the show, well, 4 of them are sitting right here at the table with us. Next to me is Dr. Jeff Holzberlein. He's physician-in-chief at the University of Kansas Cancer Center. How are you?
Great, thank you.
Good to see you. Next to him is Dr. Ronald Chen, the Clinical Service Chief of Radiation Oncology at the Cancer Center. And then you saw Dr. Ronnie Rotondo. He was in that story. He was one of Lisa's doctors. He's the director of the Proton Therapy Center. And then Bernie Vaughn is sitting across from me. He is a certified medical dosimetrist, someone who makes sure that those protons are as precise as they can be. Gentlemen, welcome. How are you today?
Good morning.
Well, it's exciting. 1 year later, talking about proton and how far we've gone. And then, of course, we're going to get into where we headed. Dr. Rotondo, I want to talk to you, though, about Lisa, our first adult patient at the Proton Center. How's she doing?
We saw her about a little bit over a month ago, and she's been doing actually quite well since completing her treatment. We're following her regularly with periodic imaging, and thus far her tumor remains stable. In other words, no growth, and so she's doing well.
So what you wanted to see, and what will her continuum of care be moving forward? Will she continue to see you?
Right. So we will be following her long term, and so we will continue to follow with periodic scans and clinical visits, and over time. As the tumor remains stable, we will extend out that interval, but so far we're very pleased with the results.
So let's talk about, Dr. Rotondo, I'm going to stay with you because technically speaking, Lisa's tumor was benign. Someone hears benign tumor and thinks perhaps harmless. True, not true?
So not necessarily, particularly for brain tumors. So Lisa's tumor was a meningioma, which is a tumor that arises from the lining or the membrane around the brain and spine. And these tumors can be benign. They can also be malignant. In her case, it was benign. But for brain tumors, even for a benign tumor, there's very limited space within the skull or in the brain. And so even if a tumor may be benign, as it grows, it can encroach on and put pressure on some critical or vital structures, which can cause a lot of symptoms and morbidity. So it can press on optic nerves, which can affect vision, or on nerves responsible for hearing, causing hearing loss. And so even a benign tumor can cause a lot of problems in a patient. So it's important to be able to control them.
I want to stick on this video because I want to know exactly what's happening here, because we talk a lot about laying down. This treatment usually takes, about 20 minutes? They have to have this mask on. Tell us what patients might be experiencing during this.
Sure. So the process starts with something called CT simulation or mapping, and that's where patients come into the department, they undergo a CT scan, and at that time we make individualized immobilization devices that can include, kind of like a beanbag mold, and particularly for brain tumors, includes a mask, which helps to reposition them at the time of treatment in a very precise way. And so when they come in for treatment, they enter the room, they lay down on the treatment table. It's an open concept, so it's not claustrophobic, but we apply the immobilization devices, in this case a mask, and then we use laser wall and ceiling laser mounted devices to help with the crude alignment, and then take very precise imaging for the final kind of adjustments to be very precise with the delivery. All of that process on average, say for a brain tumor, might be 20 minutes. Most of that time is all that setup and imaging and making sure that we're very precise. The delivery of the radiation is really just a couple of minutes. And then once they're done, the patient is free to go about their day.
And why not use just what we call regular radiation treatment? Why proton? We've used that precision word, which seems to make sense, but help us understand a little bit more about the benefit.
So historically, these tumors certainly can be treated with photons. However, the main difference between protons and photons is that with proton therapy, we're able to deliver the radiation in a much more focused, precise manner and significantly reduce the radiation to the surrounding normal healthy tissue. And so, for instance, in Lisa's case, her tumor was close to the chiasm, which is a structure that can potentially affect, if injured, the contralateral vision, but also a lot of normal healthy brain and temporal lobes. And radiation to those structures can cause lots of long-term side effects in terms of issues with short-term memory, concentration, significant impact on quality of life. And so with proton therapy, we're able to significantly reduce that radiation dose to those surrounding structures, and therefore maintain good, high level of local control, while significantly reducing both potentially acute and late effects of treatment and improved quality of life long term.
Dr. Chen, this makes it particularly good for children. Explain why.
Well, what Dr. Rotano was just saying, where proton therapy is able to treat the tumor and also be able to reduce radiation to surrounding tissues, actually is a concept that can truly affect a lot of cancer patients, both adults and kids. I mean, if you have a cancer, you want the radiation to go to the tumor and not go to the surrounding organs. But I think it's good for kids, because for kids who have many years ahead of them are still growing, the organs, we really want to minimize the radiation and damage to those organs, so as the kids grow up, they don't have sort of these long-term late effects. But we've treated many adults and many children in our first year of the program.
What type of tumors and cancers are you treating?
So we can treat potentially tumors anywhere from head to toe, really. Some of the common things that we've been treating are things like brain tumors or skull-based tumors, head and neck cancers, tumors where there's a lot of critical structures or sensitive structures to radiation. We've treated certainly abdominal and pelvic tumors, things like lymphoma, breast cancer, prostate cancer. So you can really use proton therapy to treat any tumor. It may not be the best option for each case. We evaluate each case independently and determine at that time whether we believe proton therapy is the best choice.
Not one size fits all, that's for sure.
Correct.
So Bernie, I want to bring you in. You're a dosimetrist. Tell us what that is.
Right, so as a part of the team with doctors and physicists, therapists, nurses, and others, my job is to specifically decide how best to deliver the radiation to the patient. So when you think of a dosimetrist, you can think of dose or radiation dose in this case. And what we want to do is maximize dose to the tumor itself or the target, and we want to minimize dose to the surrounding healthy structures, the healthy tissue. And so what I do is when the patient comes in for a simulation, as Dr. Redondo mentioned earlier, we get a scan of the patient. I take that scan, complete any registrations that we need with MRIs or PETs, so that the doctor can visualize the cancer itself, so we know where to treat. Then I delineate all of the OARs, organs at risk, or the healthy tissue, such as the heart, the lungs, wherever the treatment is for that specific case. And then I decide how to arrange the beams, and I decide, I have to create specific planning structures. It's pretty involved, and to get the optimal solution for every patient. Every patient is different. Every patient has a different kind of cancer. Every patient's anatomy is a little bit different. So like you said, it's not a one-size-fits-all.
Dr. Rotondo, how important, though, is someone like Bernie to making sure you're delivering the best care possible to patients like Lisa and beyond?
So, that's critical, and we work very closely together. And it's, as Bernie was saying, each case is treated individually. There are very particular factors for each case that dictate, what's the best approach. And so it's really important, having, the machine is one thing, but it's really the people behind it. And so we're really fortunate to have people like Bernie that have lots of years of experience and technical skill in being able to assess each individual case and helping guide us in terms of what's the best approach and how we can deliver this most effectively and leverage the benefits of proton therapy for that patient.
Okay, I don't know how we nab this guy, but we've got to brag on Bernie here for just a second, because you won a couple of competitions called planning challenges out of 100 dosimetrists all over the world. You ranked #1.
Right, so these planning challenges are unique case studies, essentially, specific to different treatment sites. Professional organizations will sponsor them, such as the AAMD, which is the American Association of Medical Dosimetrists. And I get the CT data set. Anyone can participate, physicists, anyone who knows how to plan can submit their solution. Each planning challenge has a certain set of goals for that specific case. It's usually tied to or involved with some kind of research project. And then each of the goals has a certain number of points assigned to it. And then your solution is tallied, the score is submitted, and then those scores are compared to other scores from around the world, whoever participates.
So no big deal, just all in a day for you.
Can I chime in?
Yes, you can.
So I just want to sort of talk about how important a dosimetrist is, like Bernie, and what a big deal this planning challenge is. I mean, this applies to proton therapy, but also applies to any type of radiation. The dosimetrist basically helps us figure out for each patient how to aim, and they draw the path from the beam to the tumor. And if you can imagine, for any patient, like a lung cancer patient, there's a million different paths the machine can go. And actually, it's an art for the dosimetrist to figure out the best beam paths that together will hit the tumor the best and avoid the organs the best. And I believe the world challenge that Bernie won was a lung cancer case. And was it 500 submissions? Hundreds of submissions where everybody did their best plan to figure out how you can kill the lung cancer and spare the lung and spare the rest of the lung tissue. And Bernie had the highest score, the best plan. And so not only is every hospital's radiation plan different, every patient's radiation plan different, and we have the best in the world.
Yeah, okay, that's a pretty big deal. So I love that story. And Dr. Holzbrein, you're up next, because we've been talking about different types of cancers and tumors that proton treats, and prostate patients. That's who you see in clinic quite often. Tell us a little bit about how beneficial proton is for those types of patients.
Yeah, and I think as has already been mentioned by Dr. Tanner and Dr. Rotondo, that prostate, like a lot of organs, has a lot of critical structures nearby, and reducing side effects of any of the therapies that we use for prostate cancer is really critical. So we're very fortunate to have been able to have a proton unit on campus now, and to be able to treat prostate cancer patients very effectively with this treatment method.
And we talk about proton therapy kind of being this so-called tool in the toolbox for treating cancer patients. As physician-in-chief of the Cancer Center, just what has it been like, just kind of watching this happen over the last year? We're talking about our 1-year anniversary today, and just what is exciting you?
Yeah, so lots of things are exciting, and I defer certainly to my radiation oncology colleagues, but as a comprehensive cancer center, I think it's critical that we have all of the state-of-the-art treatments for cancer patients, and certainly proton therapy is one of those. I also think it's critical because it's going to be a great research tool as well. And one of the things that we know is critical in order to advance the mission of a comprehensive cancer center is to be able to do leading edge research. And this proton unit will help us do that.
About how many patients have we served so far? Have we treated so far?
So far, as of in the last month, about 159 and counting.
Yeah, and so tomorrow is our exactly 1 year. So I think as of last month, 150 something. I think as of this week, 172. I think it would be sort of the end of the first year.
Right on track. And higher numbers than originally thought, or is that about on track?
Yes, I think we're on track, if not exceeding, and in terms of our ramp up, considering we've been only active for 1 year. We've had one of the quickest ramp ups and highest census of many of the proton therapy single center proton therapy units that have come on in the latest years. So it's been very exciting.
And just for people who are learning as we go, a lot of our viewers know about the Proton Therapy Center and have watched it unveil over the last year. But for folks who don't know, just how rare is it, and how many are in the country, and why is it so important that we have one here and accessible to folks in Kansas and the surrounding states?
Well, we were the 39th proton center in the whole country. The fact that there's 50 states and only 39 proton centers means that many states don't have one. Actually, some of the states on the East Coast and maybe the South have multiple. So there's really a number of states surrounding Kansas City, north of us, west of us, that don't have proton therapy. I think the fact that in the first year we were able to treat so many patients and we ramped up so quickly really speaks to the fact that the cancer patients in this region really needed this tool, and that's the best for these patients' cancer treatment. And so really I think speaks to the fact that we're being able to meet this need with the proton therapy program here at KU.
All right, be sure to ask your questions to our panel today. You can go to YouTube, Twitter, Facebook. You can email us at the Medical News Network. The information is right there on your screen. Let's get a quick check on our COVID count with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Welcome back on this Monday. How are you?
Good, thank you.
Good.
Yeah, we got 4 smart doctors over there, and
right?
then me. So
Stop.
good.
I know.
I think we're doing good.
We are doing good.
Actually, as far as the COVID count, we are doing very well here at the health system. 18 total, but only 6 active. None in the ICU, none on the ventilator. So I think we are hopefully getting to where we were a couple years ago when we had those single digits and maintaining those single digits. We know the virus is out there circulating, but overall it is much better, impacting fewer and fewer people's everyday lives, which is always a good thing.
All right, I did the COVID count for you on Friday.
Yeah.
It's the first time.
Uh-oh.
I think
hope it went okay.
I liked delivering the double goose eggs, though, the 0 and the 0.
Yes.
That was really good news. All right, so I've got to run this headline by you. We've got a COVID vaccine headline from the World Health Organization. Last week, the WHO recommended that the next booster shot should be monovalent and only target the Omicron variant that is currently circulating. Now, currently, we have bivalent boosters that target an earlier version of Omicron plus the original Wuhan strain. So do you think the FDA should follow this advice, and what difference really does it make?
Yeah, I mean, I think they already are. Again, for the vaccines, we remember there was the original monovalent, and then there was the bivalent booster. Right now, all the monovalents have been removed from U.S. health system at this point in time. So we are only dealing with a bivalent at this point, but what we do understand is that also the viral dynamics are shifting, where it was kind of the virus all the time, no matter what season. We are believing it may be getting into more of a seasonality. However, there will probably still be more circulation than, say, some of the other respiratory viruses, even throughout the year. And this also, now, we are able to understand what kind of maybe strain or variant is circulating. I think it is important because we do want to help and maintain our antibody responses so that we can help reduce infection, but also maintain those good T-cell responses. And if we could start to tailor it as the viral viral variants have maybe slowed down a little bit. We know that currently everything that is really circulating is an Omicron sublineage. And if we can do that and identify maybe that particular variant or lineage, we can probably maximize our immune response to that new vaccine variant. I think that's good, and we'll have to wait and see ultimately what our CDC and FDA says, but I think it is good. We are starting to maybe tailor it more towards any circulating or close relative of a circulating variant. And we just want to, and this is more evidence that we just want to continue to understand that yes, for most people the virus doesn't affect, but there are those subpopulations where it can be extremely devastating, causing hospitalization and severe disease, especially for those people that are older or who have immune compromise. So it is very important to try and maximize our vaccination benefit, to try and maximize their potential to stay out of the hospital and stay out of the ICU.
Doc, thanks so much. Appreciate it. Good to have you back.
Thanks.
80 reporters with us today. All right, let's get to our community questions. And Dr. Hurtado, you touched on this, Kim wants to know the types of proton beam therapy, the types of cancers that they treat, but maybe what are they most beneficial for at this point?
So again, proton therapy can benefit lots of different tumors at various body sites. Certainly some of the most common indications are things like brain tumors, head and neck cancer, pediatrics, certainly ocular tumors, tumors around or about the spine, tumors in the chest close to the heart or other critical structures, abdomen and pelvis, for instance, prostate cancer. And so really for tumors where leveraging the benefits of proton therapy can help decrease radiation to a particular normal healthy tissue or organ to reduce either acute or long-term effects of treatment. So there's really a quite broad in that list of indications. There are other tumors that are being investigated all the time, and that list of indications is growing.
Sure.
With increasing, data and studies that are being published.
Dr. Chen, anything to add?
Well, I just want to say, I think in theory, any kind of cancer can benefit from proton therapy. I think the tumors are closest to important organs that we need to protect, as Dr. Hurtado said, are really good for proton therapy. Also, if we're treating a really big part of the body where there could be lots of organs involved, I think those are especially good cases. But really, a lot of different cancers can benefit. And we, Dr. Rotundo, myself, our entire team, we see a lot of consultations every week. People here asking about protons, and we'll evaluate that and sort of match the right treatment for the right patient.
Yolanda wants to know any side effects to proton therapy.
So there can be side effects like with any treatment. There's always some risk of side effects. Typically, comparatively to photon therapy or conventional radiation, proton therapy offers the possibility to reduce or have lesser side effects, and that can be both acute during the treatment and shortly after, but also long-term, and typically potential for improved quality of life long-term. In terms of the exact nature of the potential side effects that one can experience, it's really dependent on the body site or the area that we're treating and the specifics about that case and the proximity to certain structures. So it's difficult to answer that kind of in general. I would just say that the take-home is that like any other treatment, there can be some risk of side effects, but with proton therapy, those risks tend to be significantly lower than with conventional radiation. So
on that note, Alex wants to know just what's the follow-up time frame, or does it vary from patient to patient, just to make sure that there are no adverse side effects? So that again, tends to be patient-specific and tumor-specific. There are different kind of surveillance recommendations that we may make, but all patients are followed long-term, and typically for some patients that might be every 3 months. For other patients, maybe every 6 months, and over time, as we see stability. That interval typically increases over time, but we tend to follow patients long-term to monitor both for tumor control, but also to look out for any potential effects from the treatment. Randy wants to know, Bernie, how long does it take you to come up with a plan for a particular patient? What does that planning process actually look like?
Okay, it really depends on the specific case. There was a case that we had that was very complex recently that took me 2 weeks to make. But I would say typically it takes anywhere from 1 to 3 days. But that's just my portion of the actual process. There's the whole process for protons. We have a 13-day care path from when the patient comes in for simulation to when they're actually treated on day 1.
Ruth Ellen wants to know, do area healthcare facilities send patients to KU for proton therapy? And what does that look like? What does the referral process look like?
I'll defer that, Dr. H.
Yeah, so absolutely. I think that we've seen a lot of patients, as Dr. Chen and Dr. Rotondo mentioned, who are interested in proton therapy, and it's not always the correct option, but I think one of the great things is that we have such a fantastic radiation oncology department that they come, they see the expertise, and proton might not be right, but another therapy might be the right option.
Well, because then people hear this and think, wow, I want the best of the best. So they can come here, be referred here, and then let's say proton is not the right option for them. What would be the next step? Are you there to help guide them in sending them to maybe bounce them back to the right spot?
Yeah, absolutely. So I think the KU Cancer Program really has an incredible navigation team. And whether the patient's interested in protons or robotic surgery or CAR T therapy, they just have to call our navigation team and with their diagnosis, and they will be navigated to the right team of physicians to do the consultation. And we have many patients who call a navigation team and say proton therapy, and they may come to see me or Dr. Rotondo, and we'll say, well, for your diagnosis, maybe you need surgery, for your diagnosis, you need something else, and we'll get them. So the navigation team will get them to the right doctor for the right treatment, and proton therapy is one of them.
And those navigation teams are great because they'll give you a call back within 24 hours. And that's, I think people think you're going to call a big place like ours, it's going to take forever to get to the right people, and it's so nice to know that they're on it.
Yeah, and I'll just add that, I think physicians can call a navigation team and make a referral. Patients can too. We get a lot of patients who call because they want a second opinion or want to hear about protons. So anybody, patients, families, physicians, they can all do that.
Dr. Rotondo.
Yeah, I was going to say we really set up the program so that there's a single point of contact through our Proton Navigator, and they really tried to make that process seamless, whether it's a patient reaching out or whether it's a referring physician, in terms of facilitating record collection, setting up the consultation, answering all the questions, and so it's really an easy process. The other thing I would say is that proton therapy is a tool in a large toolbox of tools that we have here at KU Radiation Oncology department, which is really a really comprehensive radiation oncology department. So we have proton therapy, which is very exciting, but we also have the full gamut of different modalities of radiation. And so when we see a patient, we really evaluate each case independently and determine what is the best option for that case. And sometimes it may not be proton therapy, and many times it may be. But the only way to know that is to reach out and get an opinion.
Walk through the door.
Yeah.
All right, I want to get today's takeaways from our experts. And Bernie, let's start with you. What do you want folks to take away from our talk today?
So I think it's important to know that there are several people involved and invested in every single patient and their case. Many of these people you may see, and many of these people you may not, and many of these people you may never meet. But all of these people are determined and devoted to giving each patient the best care possible.
Dr. Rotondo.
Just to highlight that we've now been in operation for a year, and I've been treating patients, both locally and I would say greater than a third of our patients have come in greater than 50 miles from our location. But that we're here, that we have proton therapy, that it's a very precise, focused form of radiation that can help potentially reduce both acute and late effects of treatment and improve the quality of life of patients, and just to encourage people to seek out an opinion if they or their loved ones are needing treatment.
Dr. Chen, what's the takeaway?
Well, I just want to say I think proton therapy is very exciting, but it's not just the machine that we bought. I think the team behind the proton therapy is probably even more important. I mean, we recruited from all over the country physicians who've had years of proton experience to make the right recommendation for the patient. We have the world's best dosimetrists to create the best plan for every patient. We have physicists who actually understand the machine and how it operates. I think the team that's behind anybody can buy the proton machine, but the team behind it is really important.
Dr. Holzbeinlein, take us home.
Yeah, I think that it goes back to that saying, and why would you go anywhere else? And now with a proton unit, there's really no reason to go anywhere else. And we believe that we have really one of the world's best cancer centers, and the team, the radiation oncology team, along with all the other teams that make up the cancer center, really provide that world-class care to our patients.
Gentlemen, thank you so much, and thank you to all those people behind you that stand behind you and take great care of our patients. We appreciate you very much. Thank you. Thank you to all of our viewers as well for being with us today. We'll see you back here tomorrow at 8. Coming up tomorrow on the Morning Medical Update. When a classmate needed a bone marrow transplant, one college student launched a campus-wide search for the right donor. I'm Jessica Lovell on the next Morning Medical Update. The remarkable outcome that is helping save more than one cancer patient. Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.